Good afternoon, everyone. Thank you for coming to this year's Hans Keulen Memorial Debate. It's sure to be a good one because we're going to be talking about rehabilitation, and it's a topic that's timely, it's relevant. There are a few things. We are going to be recording this year's session, the same as we did last year. So you'll see cameras, and don't worry about those. We are also going to be live streaming today's session because last year we had a lot of patients, a lot of advocates say to us, you know, Dave, I can't get to the session. So we decided this year we're going to bring the session to them. So around the world, people are sitting at home that could not come to the Congress, and they're watching this unfold live as we speak. So very exciting this year. My name is Dave Duplay. I'm from Vital Options International. My colleague Keulen Long is also from Vital Options International. We'd first like to thank Janssen and Roche for sponsoring today's session. Very important. They're doing great work. You know, I've got to attend some of the sessions, and to hear the advancements in science that's going on for cancer patients is truly amazing. A couple things. Let's see here. Live stream, we talked about that. You know, I am truly humbled to be here. This is our third year here at ESMO. We were in Vienna, we were in Copenhagen, and here today to bring you this session. Again, after the session on vitaloptions.org and Healthio360, you'll be able to see all the video, the session that we took. It'll be edited. There's going to be time for questions. So there's going to be mics roving around. If you have a question during the session, because it is meant to be interactive, raise your hand. I would ask, though, that you wait till the mic comes to you before you ask your question. Please also state your name and the organization that you're here representing so that we can put that in the video as well. So right now, I'd like to turn it over to my colleague, Keulen Long, because before we get started, we have a very special award that's being presented to a very special individual, and I'm going to let Keulen present that.
Thank you, Dave. So to echo Dave, thank you all for being here and participating in this. We are so honored to be able to work with you all. And at Healthio360 and Vital Options International, we truly believe in the spirit of collaboration. And so with collaboration and full transparency in mind, I want to let everyone know that last year's ESMO and this year's ESMO are very special to me in that hours before stepping on the flight last year to go to Copenhagen, I had my first ultrasound and mammogram, and shortly after coming home, was diagnosed with triple-negative breast cancer. I will be returning home this week to be continuing with oral chemotherapy, so it's been quite an adventure, and I'm so thankful to have the ESMO community as my support, because you know, who better to have with you by your side. And so, as Dave said, we have a very special award for a very special person. We give this award through Healthio360 to recognize and thank men and women who work tirelessly to help others in need, bring awareness to health causes, and strive to make the world a better place. Each day, these champions make a selfless effort to positively influence someone else's life while putting their own personal challenges aside. Now, some people have some great things to say about this year's award winner. It's been said that she is an extraordinary person. She has all the qualities of a perfect advocate. She asks herself every day, what have I done? Have I done enough for cancer patients today? And so it is with great pleasure that I present this year's Our Human Spirit Award to none other than Kathy Oliver.
Thank you very much,
It's not
Dave.
in the script. Sorry.
Yes, this is certainly not in the script, I can promise you. And I think, that's amazing. For once, you're looking at a patient advocate who's speechless, really. Well, I'm just really honored to receive this. And I do so on behalf, really, of the many patients and caregivers who we serve as patient advocates. They're really the true heroes, you know, the true people who we're here for and who we work so hard for. I also want to say that I think the best work we can do as advocates is teamwork. And I've been very, very fortunate and privileged to work in a really large range of various initiatives, multi-stakeholder initiatives with clinicians, with industry, with academics. And their inspiration to our community of advocates is truly inspiring as well. So on behalf of the entire cancer community, really, I thank you all, and I'm very grateful for this. I hope someone has a tissue they can lend me in a minute, but I thank you, Dave. It's always prepared. But it is a huge surprise, but a very huge honor. So thank you very much indeed. Thank you. Thank you, Courtland.
Thank you so much, and good luck for your treatment.
Thank you.
Well, and for those of you who would like to see, it's a beautiful certificate. And we'll have pride of place in my home. So thank you again. Now, I'll try and find my words again and welcome you on behalf of the ESMO Patient Advocacy Working Group to this unusual session. As Dave said, we're in the round, and we want you to treat this as though you were amongst friends, discussing various issues informally, and almost as though you were sitting in your own living room talking to some friends about the rehabilitation in the cancer journey. But before I start, I must introduce my co-chair, who is Professor Françoise Meunier. And on behalf of both of us, we do want to welcome you. Thank you for making the effort on this very busy day at ESMO on this Monday. Now, I hope that the next hour or so really provides a good forum for us all to chat together. But before we get started, I do need to explain to everybody why this is called the Hans Keulen Memorial Debate. Now, Hans Keulen, some of you may have known him. He was a self-employed businessman and a married father of 3 living in the Netherlands. He was diagnosed with a rare skull-base chordoma in 2009, and he sadly passed away in October 2015. Now, in the intervening 6 years, Hans championed research, treatment, and support for not only chordoma patients, but those with rare cancers. Sorry?
Twice.
There's an echo. Is there? Can we get rid of the echo on the sound? Okay. Is that better? Okay. To continue about Hans, he was the driving force behind the Chordoma Foundation in Europe. And even while in very poor health himself, he managed to continue to advocate for rare cancer patients and patients with chordomas. He was passionate about rehabilitation. So we're very proud that this session is named after him, and I fear there may be continuing echoes. Are you okay?
I'm okay.
You're okay.
I think it's just because you're speaking, and then we hear speaking, and in a delay we hear it.
Okay. Maybe I'll go to the front of the room. So the other person we are honoring today is Selma Schimmel. And this session is being recorded by Vital Options International, as you know, so we're also remembering Selma. She was diagnosed with breast cancer at age 28 and became an outspoken cancer patient advocate and activist and founder of Vital Options International. Now, Vital Options International was America's first nonprofit organization for young adults with cancer. She also created the Group Room, which was a syndicated radio talk show all about cancer. And she also established Advocacy in Action, which is Vital Options' signature platform for bringing together a cross-section of cancer patient advocates, as we all are here today, and enabling us to discuss various issues in our community. So, let's get going with the discussion, having explained to you who the people are that this is in honor of. And to start with, I'd like to ask Professor Meunier to share her thoughts with us on rehabilitation. Now, Françoise, you are Director of Special Projects at the European Organization for Research and Treatment of Cancer. And that's based in Brussels, for those of you who weren't aware of that. And you have a special interest in cancer survivorship. You're very outspoken about this. I know you've given a fantastic TED talk, and I recommend that talk to everybody to watch online. But perhaps you'll tell us more about the topic now, and then we can get the discussion going. Thank you.
Thank you, Cathy. Thank you, everybody, for being here. I'm the former director of EURTC, a unique pan-European clinical research organization in Europe. I was graduated as a medical doctor in 1974. At that time, announcing to a patient a diagnosis of cancer was a death sentence. And I decided to dedicate that part of my professional life to the improvement of survival of patients with cancer. We have made tremendous progress in the last 45 years. Those progress do not come from the sky. And I am very thankful to almost 100,000 patients who trusted us, clinical investigators, who accepted to participate in EURTC clinical trials to reach where we are now today. Today, cancer is no longer a death sentence. And as you may know, we have made tremendous progress in testicular cancer, in Hodgkin's disease, in breast cancer. There are still some cancer much more difficult to treat, but I'm convinced that in the next 5 to 10 years, we will again make tremendous progress, thanks to the patient involvement and empowerment. Now, I'm no longer the Director General, I am Director Special Project because I decided to dedicate the last part of my professional life to survivorship. And here it's important to maybe make a parenthesis of definition because sometimes there are misconceptions about rehabilitation and survivorship issue. As much as I support and ask for rehabilitation from day one of diagnosis to help the patient having to go through an ordeal to get treated, as much I think there are different issues when we doctors, we tell to a patient, you are cured, I don't want to see you anymore to do all of those extra tests, live your life, get back to a normal life. That's what I think we should call survivorship issue. And at that time, there are new issues that did not exist when I was graduated as a medical doctor. Nobody really cares about, do you get a job, do you get a promotion, do you buy a home, do you get an enterprise? I will give you an example. If you are 29-year-old, finishing business school, very entrepreneur, very successful, very ambitious in the right way of the wording, and 2 months later, you are diagnosed with Hodgkin's disease or testis cancer. Are you going to a bank or an insurance asking for a loan to buy an enterprise or a home? I think we should not ask to the bank, an insurer who are extremely risk-averse, to put in the same package everybody. And that's why I think so much that we have to distinguish what we ask for and to who we ask it for. And therefore, the concept of initial rehabilitation is crucial, fundamental if we want to cure and have a better life, but also what we ask to a bank or an insurance or to the society, to the government, is different at 5 years, for example. Now, what we have done within EURTC, now that we face those societal challenges, is to create an EURTC cancer survivorship program with research and dedicated research, for example, on a EU protocol, year update data for long-term follow-up. Indeed, we are in a privileged situation because for 50 years we do clinical trials, and so we have large, very well-structured database with clinical data. But now it is crucial to not only ask late toxicity or secondary tumor, but also fertility question, job question, loan question, and so on. So it is a whole new area of research which is opening in front of us, taking the advantage and the benefit of having structured database with patients who have been entered in clinical trials, but also creating partnership, for example, with national registry, to try to see what is the extent of the problem. We have also, I have hired a legal person, a lawyer from Paris Descartes, to study the legal framework, because we want to have a pan-European map of what is the challenge in the different pan-European countries. In France, there is a very good law, le droit à l'oubli, which means that an insurer cannot ask questions or taking into account a previous cancer 5 years for a child and 10 years after the diagnosis for an adult. I think this is a tremendous positive law. And that's why I went to Paris to take a French lawyer to try to see how we can do a pan-European map and extend this French law to all European countries and to change the legal framework. And the third approach that we did in EORTC is to create, since 2014, an European Cancer Survivorship Summit, which is a meeting taking place in Brussels every 2 years, and where we discuss with patients, with health authorities, with all involved partners, the issue, and particularly the medical issue, psychological issue, but also societal issue of cancer survivors. So the solution will not come overnight. We have to be patient, going step by step. But the idea is to create, now that we had empowered the patient initially to participate in clinical trials, which lead to tremendous clinical progress, now we have to empower again the patient on different purposes. It's to make sure that we get the data on jobs, on insurance, on loan and so on, in order to change the pan-European legal framework and to make sure that there is a life once you are diagnosed as being cured of cancer. Thank you very much.
Okay, so Françoise has brought up some very, very important points. I want you to keep those at the top of your head, because we're just going to add now another aspect of rehabilitation and survivorship to the mix for you to think about, and then we're going to open up the discussions for you to participate. So I'd like to introduce Lucia Travado, and we need a microphone over here for her, because she's going to tell, she is actually a psycho-oncologist at the clinical center of the Champlimont Center for the Unknown in Lisbon, Portugal. And Lucia, you've been very, very involved in the CanCon guide. I don't know if you're going to talk about that now, but you please do mention it so that everybody is aware of the part that rehabilitation plays in that work.
Okay, thank you, Kathy. It's my pleasure to be here. I'm also past president of the International Psycho-Oncology Society, and we have been participating since the European Partnership on Action Against Cancer, which then evolved into the Cancer Control in Europe, in a number of projects that have the aim of improving and recognizing patients' psychosocial needs. As you know, cancer has a multifolded impact, so it does not only impact the physical domain, but also the psychological, the social, the sexual, the cognitive, the family, the professional, etc. So all these areas is what we need to address when patients face cancer. And in our area, the psycho-oncology area, what we face is that patients with a diagnosis of cancer, feeling the physical symptoms of the disease and the treatment, the side effects of the treatment, it disrupts their normal life, as you know. And so it creates what we have coined the term of distress, as to separate it from mental health problems, because a cancer patient does not have a mental problem. They have psychological suffering from reduced expectations of being healthy and not being able to do the things that they want to pursue. So we found out in the research that we have been doing since last century, since the 50s in the last century, that in fact distress impacts, severe distress that can go into anxiety and depression, does impact not only on the quality of life of the patient, but also on their clinical outcomes, such as survival. So the International Psycho-Oncology Society has put forward a standard in which distress should be assessed as the sixth vital sign after pain. So you know that pain took a long while until being recognized as a need that needed to be addressed. Also distress, if you don't assess it, as for instance with the distress thermometer, it will tend to go unrecognized, and patients usually do not disclose this suffering to their clinicians because they think, well, I have cancer, I have to suffer. And so they go on with this burden, this added burden of psychological suffering along with other sufferings. So because we want to stop this, we have made a call for bringing distress to be assessed in clinical centers where patients are treated, to be assessed as the sixth vital sign, and also there should be resources of psychosocial care for patients so that these needs could be addressed and properly addressed. So when we discuss rehabilitation, and as Kathy was mentioning, what we wanted to do in CanCon with the European Guide for Quality Comprehensive Cancer Care, with a chapter of rehabilitation and survivorship in which we collaborated among other stakeholders with the European Cancer Patients Coalitions and other groups of stakeholders, is that rehabilitation is a patient's right along with treatment. So if the treatment is going to bring you side effects, we should not let these be left to the patient. It's our responsibility, the clinicians and the politicians, to take care of that side as well. So the concept that we introduced, not only in this guide, but that has been discussed, is that rehabilitation is not something to happen after the treatment, but pre-rehabilitation, before the treatment. So for instance, if we know that a surgery or a radiation therapy for prostate cancer is going to create a sexual problem, that should be discussed ahead of time with the patient and the couple, if the patient is interested in that, so that they can devise measures to cope with the problem and not be facing the problem afterwards and get depressed or isolated or whatever the negative reaction acts. And while the lymphedema, for instance, in many centers, we have a preventive attitude with physiotherapy before the problem begins. And that's what we would like to make, is that rehabilitation is integrated part of a treatment. So when the treatment is planned, already all the areas that need to be addressed should be part of this plan. Now, what we have surveyed in EPAC and in the Euroship project, some projects that we surveyed the resources in this area in the different European countries, was that there are seldom resources of this kind. So as Kathy coined it, the patient is lost not only in rehabilitation, but in this transition, and most acutely in the transition from the treatment phase to the survivorship phase. So the patient does not know what to do, and it's left alone most of the times with all the symptoms. So we want this to stop, and that's why ECPC and ESMO, with the collaboration of the International Psycho-Oncology Society, have put down a survivorship guide for patients, so that there is the recognition of the areas that need to be addressed, so physical, psychological, social, sexual, cognitive, nutrition, to make a checklist of what are each patient's problems and then what are the resources that need to be allocated to each patient so that their survivorship can go smoothly and not stumble. So I have, because this is such an area of need and it's not yet in the political agenda of our country politicians and ministries of health, we have to make a push for it. And I said to Kathy that I would like to make a manifesto action of some sort while we are here in this conference or whenever appropriate, but we need to call for action in this area because this is a much underserved area and most of the countries do not have this in place, and so the patient really gets lost into this rehabilitation navigation. So hopefully we can discuss more about it and we can do something together, professionals and patients and families and advocates, all together do something to move this forward. We have good guides, we have good recommendations in place, now we need actions. Thank you, Kathy, for the invitation.
Okay, a lot to get you thinking. We've heard about insurance, mortgages, distress being, we should assess distress as the sixth vital sign. We should have pre-rehabilitation, which is a concept I've actually not explored very much. And there's a lot to talk about. So who wants to kick off? Have you had rehabilitation in your country or even pre-rehabilitation? Have you had problems getting a mortgage if you're a patient? Let's have some input from the audience. Please give us your name and tell us where you're from.
My name is
Would you like to stand up?
My name is Viorica Cursaru. I am the president of Myeloma Euronet Romania. My husband was diagnosed with multiple myeloma and died 30 months after the diagnosis. To tell you the truth, rehabilitation is the first time that I heard this term here, because in Romania, as well as in other Eastern European countries, this is almost an unknown concept. It may be known for the doctors, but not for the patients. This is something which the patients must deal with by themselves. I would like to say two things. First of all, I would like to thank you, Professor, for mentioning the fact that there is a need for a change in the policy framework and the need to establish a pan-European framework. Thank you, because you raised this issue. I want to tell you that as a member of the ECPC, during Lorenzo presidency, many attempts have been made and successful attempts, I would say. So the MPs are more aware about the problems east-west. One more thing which I would like to tackle is survivorship. Survivorship, I mean, it depends a lot on the access to medication and access to medical treatment. When it comes to these two issues, both of them are quite scarce in Eastern European countries, because Romania, it is one of those, and it is not, whatever I'm talking about is not valid only for Romania, but for the whole range of countries. If in the respect of medicine, there are generics and novel treatments, so if you don't have the novel treatment because the state does not want to spend too much, at least there are generics, thank God. This is not the biggest challenge we are facing now. The biggest challenge we are facing, and as I mentioned yesterday, is the migration of the doctors. Something needs to be done, because survivorship is in that direct relationship with the treatment. And hopefully, together with the CPC, together with some other organization, we shall be able to tackle, to trigger the attention of the European MPs, of the national government, in order to, not to prevent the doctors from immigrating, because this is their right. And the doctors are immigrating not only from Eastern Europe to the Western Europe, but also among the Western European countries. The intention is not to prevent them, but to have something in place. Thank you very much.
Okay. Thank you. I wonder, to use that famous line, is there a doctor in the house, preferably from Eastern Europe, who would like to address this particular issue? Does anybody? Ah, yes, please, would you wait for the microphone? Because I think all these issues are tied up with each other inextricably, and it would be interesting to hear your thoughts. Please let us know who you are and where you're from.
Hello, my name is Simona Ene. I'm also from Romania. I'm past vice president of European Cancer Patient Coalition. I had terms between 2007 and 2012. Currently, I'm the president of Home Care Association. It is an NGO which provides 3 great activities: public education for cancer prevention. We have a support group for gynecological and breast cancer women, and we also provide social medical services, home care. So social medical services, meaning medical services after surgery, after mastectomy, for example, which are covered by health insurance, and social services include also some of the rehabilitation issues, like kinetotherapy for recover the arm after mastectomy, emotional support. My colleague, which provide emotional support, she's a psychotherapist, and also we have social workers, but these are not covered by anyone, and they are our great volunteers provided such services. Also, the great news is that in Romania, and Lucia know, there is Ciobi Degi, which set up an association for services, social services in oncology. And he also succeeded as a great lobbyist to set up in the Ministry of Health a group which will work to include in the treatment cancer plan these social services in oncology. So we are making some progress, but these progress are just regional, not applicable to the whole country. And we have another great colleague in Romania, which is the president of Amazonia, and she succeeded to put on the professional code list the cancer patient navigator. She paid her own training in the United States to become a navigator. More or less, all of us, Viorica and other colleagues from Romania, we are somehow all navigator, not trained, yes, but coaching patients, organizing such activities. We think we are also part of some rehabilitation. Thank you.
So things are moving. That's good to hear. Now, I wonder if you have any thoughts about this distress assessment that Lucia mentioned. What does this mean to you? Will it be useful? Will it be helpful? Can we have a microphone over here, please? Then we'll come over there. And if you could keep your comments pretty short, because we want to get to everybody, and then we'll go to you.
Okay, thank you. My name's Jeanette Rawlinson. I'm here for British Thoracic Oncology Conference. I'm a lung cancer survivor. This is a cancer of very unmet need. I'm a never smoker. I did not know that so many women particularly, but so many never smokers get cancer. And I'm self-employed, so when I was diagnosed, I don't have all these fancy markers that people have, so I was not able to have novel therapies, but I had surgery. And the ignorance and the stigma of insurance companies, of medics and everybody else is quite frightening. So I cannot get 6 years out, which is quite remarkable, but because I've never smoked, I don't have some of those other issues. I cannot get travel insurance on an annual policy, and yet I am fit because I was fit beforehand. Despite losing half of my lung, I've gone on to swim even 989 miles in a year, 360 lengths non-stop. I could outstrip many, many people who have 2 lungs, but from an insurance or an employment perspective, people think I'm going to drop dead next week. So the counselling services, and I have gone as a result of going to a lung charities conference and went in a session to discuss feelings, which was the first time I'd even had that sort of discussion. I went and had 6 sessions, which is all you qualify for in the UK, but you have to wait months. It's classed as mental health services. So one of the boxes the insurers ask you to tick is, have you ever suffered with anxiety or sought help from a mental health professional? So we are stymied not only on the ignorance about the cancer, but also on the psychosocial support that I think is vital. And I also think this issue, even in the nice published booklet today on survivorship, it assumes everybody is employed rather than self-employed, because the discrimination and, as I say, nihilism and stigma is still that people would not employ me with an assignment because they think I won't be around in 6 months' time to complete it.
Okay, well, first of all, sorry you've had these terrible challenges. It's the last thing you need on top of the diagnosis, you know? I'd like to bring in Isabel Lebrocki here, because you mentioned employment, and this is Isabel's big focus. And she is going to give a longer presentation in a minute, but if you can just give us a quick response to this problem, which is so demoralizing, isn't it? You feel like you're devalued as a person. And yeah, well, then you resort, yeah. Isabel.
Well, I will not tell completely. I'm sitting in a sitting room, so I stay, you know.
Okay.
This is my living room. So, first of all, Louisa, I have very good news for you, and I would like to have a discussion later on, because Holland just installed guidelines for psycho-oncology care, and it's reimbursed by the healthcare insurances. So I invite you to have a discussion about it. And then I agree with what you say, because I'm cured from cancer. I am cured since 2 years. I have it on a paper, it's written. My risk of getting cancer is not higher than anybody else here in the room who is so-called healthy. And I can get not an insurance. I am a social entrepreneur. I cannot get a disability insurance, not an illness insurance. It means that if I get ill, if I get a flu, if I get pneumonia or whatever, I get no money. So I completely agree with the stigma, and I agree with what Françoise says, that we have to go to a right to be forgotten. And my call is to set up a sort of ecosystem, a group where all stakeholders work together to get that right to be forgotten in all the European countries where we can get them. And I completely agree. I always say, look at me, I'm a cancer survivor. I just want to take the cancer sticker away. Thank you.
Thank you very much, Isabel. I'd like to go back to Françoise to ask if you have any comments on what you've heard, some quick comments, reactions. We'll come back. I just at this stage want to ask you what you think so far about the comments you've heard.
Well, I agree with the disparity between Central Eastern Europe and Western Europe. I think if we want to go through pan-European and being in European organization, I cannot ask for anything else than a pan-European solution. Something maybe should be from national cancer plan and trying to make the notion of survivorship and rehabilitation in the national cancer plan. It could also be a pathway, but I don't want to take too much time.
Okay, wrong microphone. Thank you very much. We have another comment down here. If you'd like to tell us who you are, please.
Yes. Can you hear me? Yeah, I hear me now. My name is Sabine Spitz. I'm from Vienna. I'm a metastatic breast cancer patient from 2014, from the beginning on. I'm working with Eurodonor Austria and with Eupathia Austria. Formerly, I've been trained as a clinical psychologist and as a psychoanalytic psychotherapist, and I've worked with chronic diseases. And I know we have the guidelines for the psycho-oncologists, but they are still 50% not very good, as I could see at my rehabilitation when I was there in 2015. And they are young, they are scared, that's okay, but you need help. It would have been funny if you're not anxious when you get the diagnosis. Therefore, I think that was really stupid. I was on rehabilitation 2015. In Austria, we got the possibility in 2013, but it's not a right. You may do it, it's not a right. I've never heard about this pre-rehabilitation thing. This is very interesting. I still believe with better training, the psycho-oncologists will all raise and will become good, but it takes time. It takes time to implement them. It takes time to... It's a very special topic to be in the cancer field. Yeah. The rehabilitation I got was quite all right, and I could go on with some exercises at home. I wouldn't do it again now because I'm now further on. And yeah, the working problem, we have a new law in Austria where you can postpone to gradually reintegrate into your work for 6 months, but this is still a beginning and not the end, because I know in Germany they're far, because in my case, for example, I couldn't work for 20 hours anymore. I'm just voluntarily working now. But if I had the opportunity to work for 5 hours or 7 hours per week, it could have been, maybe. So it's not the first 6 months, it should enlarge, and there should be many more possibilities for work.
Okay, thank you. Thank you very much. We're going to get to everybody, but there's one more comment here on employment, and we're going to just have a quick word there, and then we're going to just slightly change tack, but I will come back to you.
Hello. So my name is Magali Mertens. I'm from Belgium. I'm also a patient survivor, and what I found the most difficult was return to work. And so since I've made it like my life battle to making easier for all the patients. So now I'm a Secretary General of a new non-profit organization, which is called Travail et Cancer, which means work and cancer. And my goal is to show, like, the corporations that people who had cancer, they are not a weight to society, but on the contrary, they can lift up the energy, because you know you went through hell, but you know yourself better than anyone, and you have resource. You have acquired resources, and it could be a new potential to put in profit to your company. So, well, that's what I wanted to say.
I'll grab this. Now, look, I know there are other questions here, but at this stage, I just want to bring in Stefan Rau, because we've heard from the patients now, but we have here a medical...
Can I say something from a policy point of view?
Yeah, can I just come back to you? Just 2 seconds. I've seen you all, and we'll get everybody in, I promise. No, let's go to you, Stefan. Now, let me introduce Stefan. He's a medical oncologist at the Hospital Emil Meirisch and Esch in Luxembourg, and he's one of the authors of the ESMO Patient Guide on Cancer Survivorship, which has been mentioned. And so I'd like to hear from you, Stefan, what some of your thoughts are on rehabilitation from the medical oncology point of view. So there you go, and I promise we'll come back to you, Francesco.
Sorry about that, because that's going to make a short intermission from the very passionate discussion we have. If anyone here has still a doubt that for oncologists, survivorship issues are of importance, well, with this you should not. So this is the brand new ESMO ECPC survivorship guide. And what you can see in the first chapter up front is rehabilitation. Now, if this is this important, why don't we see it on site? Why don't you get rehabilitation? And let me say, well, of course there are financial, there's political issues. It's also a question of awareness. And there's something quite fantastic about the survivorship issues. It's that we actually have long-term survivors. And this is certainly not something we were used to when I started my training. And so up to now, I think for a lot of oncologists, survivorship care corresponds to follow-up visits. And as long as I see my patients back, they look rather lively, the CT scan is fine, the blood work is fine, I'll say, well, good to go. See you in 3 months. So we have to switch gears, but there is an awareness problem like there were for many others, like for integrating palliative care into our everyday treatment of active disease. And this is a joint effort. And it is a complex effort because, well, as you already heard, it's physical rehabilitation, it's psychological rehabilitation, and it's social reintegration, which is probably still one of the biggest challenges when I heard what I heard just now. Up to now, wherever it exists, and for sure in Europe and even more around the globe, this is a very, very heterogeneous pattern. It looks like a little bit like a puzzle which is unfinished and of which some pieces are scattered around the table. What we need is we need a track. We need to know how to organize survivorship care. We need a framework. We need evidence-based because there's certainly lots of energy lost in transit because we do things which don't necessarily help you. And there's pioneer work from Françoise, from Professor Meunier on that field, fortunately, but that is quite recent. We didn't do that 20 years ago. And of course, we need an alarm bell which has to ring in every oncologist as soon as the active treatment is over, which tells him, okay, shift gears. Now we need a plan, we need awareness and a plan for survivorship. How should that work? Now, in Luxembourg, we're not forerunners. We're just implementing right now a plan with an outpatient program and an inpatient program for frail or older patients. This is not yet realized. It's going to be next year. Actually, it's not quite clear. Different countries have different systems. Usually, they work in the beginning whenever they work for a couple of weeks. And next thing, very important, of course, they can only kick off because as you can see and as you witnessed, well, survivorship goes for much more time. You were telling, it doesn't end with four weeks of cure someplace in a thermal hospital. It goes on for years. And so what we need is we need to educate. We need to educate you patients. We need to get educated as medical oncologists. And we need, again, what we do imply more and more in our everyday oncology, it's pluridisciplinarity, because who is going to deliver it? It's not the oncologist, or certainly not only the oncologist, but it can be a GP, and who knows, in some countries it's going to be the general practitioner who's going to take back the patient as soon as the active treatment is gone. So it won't be the oncologist. And we need nurses, physiotherapists, we need psychologists, we need social assistants, and so on and so on. And sorry for those who I forgot. So all of these people, we got to put in a framework, we got to organize, to sit together, to have some kind of checklists. I love checklists to get this started, and we have to have a rational way to put people on the track. And hopefully we get there quite soon. Thank you.
Before we get into the discussion, I give the floor to Lorenzo, who asked a question.
I think it's a good idea to have these meetings just to know what each other is doing, because I was listening to do new things in policy and hoping that a policymaker will be involved and so on. But do you know that there has been a joint action on cancer control? Do you know that joint action on cancer control is a commission initiative that is giving a lot of effort for cancer? Do you know that cancer patients, ECPs, has been part of this joint action cancer control, and that the final result of the joint action cancer control that ended in February is just to use the recommendation that has been formulated and shared by 17 countries in the national cancer plan. So now the fight is each one of us belonging to 17 countries to fight in their own country for implementation of this. Because if the survivorship care and rehabilitation are not put in a national cancer plan, nothing can be done. So not start all over again. Let's work together to see what we can do using the recommendation. And the recommendations that have been done, Lucina knows very well, was quite hard to establish the principle of rehabilitation, including nutrition and so on. We had to fight together, and we had also to work to reach, I think, the most important results within the recommendation, to have a survivorship cancer plan. A survivorship cancer plan is the real tool that gives the opportunity to the patient, once the acute treatment ends, to know, being free of diseases, what should be his knowledge or her knowledge about rehabilitation, taking in full consideration late effect, second primary tumors, and then having this tool in the hands. There is an empowerment of patient and their family, and then is this the link between the medical oncologist and general practitioner? Because the patient can go and tell, look, now we don't want to medicalize, but at least knowing what the medical practitioner is doing. And the nice thing is that in the same recommendation, in the rehabilitation, is included to go back to the work. So that is part of recommendation. They should go in the national cancer plan. We in Italy already had a meeting with the government, and we are putting this in the national cancer. Why don't we exchange this information and work all together? The last thing that I want to say is that the role of cancer patient organization is to be a link between policy and practice. And we are very much indebted to ESMO because we were doing a memorandum of understanding and we were working together. So the recommendations that have been approved in the joint action on cancer control, together with the ESMO people, all very much devoted to this. We were doing a booklet where those recommendations are already included. So that is also a good guide for each one of us to go and use this as a tool for working together. And I really feel that I was telling yesterday in the meeting we had in the press conference, in the meeting with also the president of Bernero, that is a breakthrough. Also from a cultural point of view, because the idea of ESMO is to send it to all medical oncologists this, to let them know what survivorship plan. I think we have to continue to work because it needs to be updated, but now the door is open. Let's go to work together.
Thank you. Thank you. To get back on a remark on the very nice presentation of Stefan, I think there is a new challenge and a need for change of mindset. We are not used to have so many survivors around us. There are today 32 million on the planet.